Hello, everybody. Field's partner in A&T Lectures. I'm also a professor at Rutgers University, a lead therapist at a major medical center in North Central New Jersey, as well as the co-editor of 3 textbooks in respiratory care, including Egan's Fundamentals of Respiratory Care. I'm coming to you today to present a lecture that's part of a series of lectures relating to sleep medicine. Okay. Now, I've been teaching about 30 years, mainly respiratory, but I teach other courses in healthcare management and things along those lines as well. And what I like to try to do is, before I go drilling down in a topic, I like to cover why it's even important. Okay. Why sleep medicine is important. It may simply be important to you because you simply want to learn more about sleep medicine, which is a completely legitimate reason to sign in with us and listen to these recordings, answer the questions at the end, and get your continuing education credits. That's a legitimate reason. However, one of the other important reasons is we now know certain things we didn't 20 and 25 years ago. One of the things that we know is that untreated or undertreated obstructive sleep apnea carries with it many potential comorbidities. Amongst them are things like psychosocial disabilities and problems, such as depression, an array of cardiorespiratory and cardiovascular disorders, such as high blood pressure and heart failure, as well as other potential problems, such as folks that can develop diabetes, particularly insulin-resistant diabetes. There are others as well, but those are some of the major comorbidities that we now know are linked to untreated obstructive sleep apnea that we really did not fully understand even as recent as a decade or two ago. This particular lecture is going to cover a clinician's guide to positive airway pressure, or PAP, adherence. So now let's take a look at some learning objectives. So over the next 50 or so minutes, we're going to review some statistics related to positive airway pressure and obstructive sleep apnea. In addition, we're going to discuss ways to monitor adherence to positive airway pressure. We'll then evaluate some of the barriers that exist to the adherence to this form of therapy. We'll describe some strategies which basically promote successful adherence to this form of therapy. And probably most importantly is to provide you with additional related resources if you want to drill down more and learn more about these topics. It's difficult to cover in less than an hour, to cover every facet that's related to adhering to CPAP or BiPAP therapy. It's just not possible, and I think that you guys would recognize that. So we provide some additional resources for those that really want to know more about it, that perhaps want to fill some knowledge gaps that they have, or you know how it goes. The longer you've used knowledge that's in your head, the less apt you're able to recall it. So to be able to kind of reinforce some of the topics that you perhaps have learned about in sleep medicine, in addition to additional information we've covered now, and you'll be able to, if you will, complement that with the additional resources that we'll provide you with. So some studies show that patients having OSA, or obstructive sleep apnea, typically go undiagnosed for up to 10 years with steadily increased use of healthcare resources. That's another way of saying, if you go for a long period of time untreated, undiagnosed, that you tend to be sicker, you tend to have more health problems, and you're more likely to use our health facilities, hospitals, doctors, clinics, and the like. And again, some of the comorbidities associated with obstructive sleep apneas, if you will, OSAs, or diabetes. And it may be that diabetes, newly diagnosed diabetes, or it may be diabetes that was previously well controlled, that is no longer well controlled. Or it's maybe somewhat well controlled, but it's a delicate balance because now the form of diabetes the person has developed is more insulin resistant. Another form of comorbidity is hypertension, because what actually happens is the unfortunate reality is that an individual who has obstructive sleep apnea, they have a cessation of breathing. Usually it's many, many times over the course of the night. And we know that in and of itself creates problems. It creates, if you will, reduction in pulse oximetry, and if you will, oxygenation of the arterial blood, which can result in tissue hypoxia, which is one of the reasons why individuals can wake up with a severe headache who have untreated obstructive sleep apnea, is that their brain wasn't totally deprived, but it wasn't quite getting enough oxygen over the course of the night. So we know that there's those issues. What we now know, however, is that the awakening, with each resumption of breathing, there is the release of stress hormones. And these stress hormones are the same ones that are associated with the flight or fight response. So it is, things like, the bronchodilation, the increase in heart rate, the, if you will, increase in blood pressure, or, the increase in vasomotor tone of the actual vessel. So they constrict. And what can happen is, if it's just a couple of episodes a night, it tends to be not a real big deal. If it's occurring tens or even hundreds of times every night, night after night, eventually the levels of these stress hormones remains elevated, and the patient either can develop hypertension, or if they have hypertension, it can be a more severe form and one that does not respond as well to conventional therapy. Likewise, the individual can develop heart disease. And the heart disease that they would develop would be really secondary to the constriction of the vessels, that the right heart now has to pump harder. The right heart preload, is greater because the pulmonary artery is now more constricted than it otherwise would be. The left heart is now, if you will, beating again, to try to perfuse tissues, but the pipelines, the vessels are more constricted. So that left heart has to work harder. So again, untreated obstructive sleep apnea can contribute to heart disease. And for a similar phenomenon, it can contribute to stroke as well. There are others. Again, for the sake of time restrictions, I'll move on to the next slide, but you're getting the point. The point is that there's more comorbidities associated with untreated obstructive sleep apnea than daytime sleepiness. So some of the, again, positive airway pressure, I mentioned CPAP here, but it certainly can be, BiPAP as well. So OSA occurs in an estimated 5% of the adult population. Okay, it's further estimated that well under half of the folks that have it are actually diagnosed. And of the ones that are diagnosed, many are not fully compliant, which is really the focus of this particular lecture. CPAP remains the first line of treatment for moderate to severe obstructive sleep apnea. In a related lecture, we actually talk about some of the alternatives or complementary treatments in addition to positive airway pressure. CPAP is almost 100% effective when used regularly, but adherence remains a challenge. To talk about adherence, we're talking about a flow generator. So even though we've had some really nice refinements to positive airway pressure in the past 10, 20, 30 years, it still remains the fact that you have a flow generator, you have a tubing or a hose that connects to an interface. There may or may not be oxygen that's bled in, okay? But irrespective, it's anywhere between 80 and 120 to 125 liters per minute of air or oxygen enriched air that's being blown into the patient's airway. So there's nothing natural about this. So the whole notion of, adherence, because again, you have this kind of this fire hose effect. On top of that, you have an interface that may, contribute to some forms of claustrophobia. So the individual who, has a little bit of a fear of being closed in, they may have some work to do, and we may have some work to do with them in order to get them over the hump with any proclivity they have to, being claustrophobic. The provision of CPAP involves more than simply selling a device and a mask and tubing and a plug that goes into the wall. It involves education and us as educators. So I'm an educator. I teach at Rutgers and I teach at County College of Morris, where I teach actually respiratory care. But I always said, even before I formally became an educator, that as a respiratory therapist, I was an educator. I did home care full time for almost 2 years. And I remember a big part of my job was educating folks on, whether it be CPAP or BiPAP, invasive mechanical ventilation we had some trach patients that came home who were ventilator dependent, the use of various forms of oxygen therapy, nebulizers, suction, et cetera, just airways in general. So we do a lot of education. Certainly we do a lot in the hospital, but even more so when you're in, if you will, an alternative type setting such as home care or skilled nursing facility. Monitoring, so it involves education, involves monitoring. So monitoring, initially the monitoring may be clinical monitoring. How's the patient doing? How does their pulse oximetry trend and their blood pressure and their vital signs? How does that actually trend over a period of time? But the other form of monitoring we're talking about is monitoring the patient's compliance with the therapy. In the day, and I say that 28 or 27 or 28 years ago when I did home care full time, a lot of it was the honor system. You went to a patient's home to check, to check on them and to check on their equipment and their compliance with the equipment. And they would swear up and down that they're fully compliant. And then when you wanted to inspect the equipment, maybe to change the filters, et cetera, maybe change the tubing and the interface, the flow generator and associated equipment were at the bottom of the closet, covered with dust, and you didn't have to be a genius to say that they really hadn't been using it in a while. Today, it's the dawn of a new day, and it is this equipment is all interfaced with the internet, and it's all monitored as far as how often it's being used, how many days a week for how many hours, and if it's not being used, it will be taken away. And the mindset is, there'll be some intervention. It's not taken away, the first second that that's discovered. There'll be some intervention, some education, some monitoring, some support, et cetera. But ultimately, if the patient continues to be non-compliant, the equipment will be removed. And it's really sad because then it's removed and the patient's in need. So again, there's in a sister lecture to this one, we actually talk about some alternatives. There is hope out there. There's more hope than there was a decade or two ago. When I say that, so we talk about the education, the monitoring, and support. It's a shared responsibility. The patient has some ownership for this. So we may be doing the educating, but they need to be asking the questions. They need to be taking the notes. They need to be looking at the whether it's printed out and or web-based resources that are out there. What I like to say to my students is we have a teaching learning partnership. And if I'm not teaching well, and you guys are not doing your part as learners, then the relationship breaks down, okay? Likewise, the patient needs to be a part of this. And I'll say patient / family support, significant other / family support. So it's the patient, but many times we're educating not just the patient, but others as well. There's also the sleep physician. And that is often a pulmonary critical care physician or just a pulmonologist, but not exclusively that. So they're not just prescribing, but when there's an ongoing issue with, even if the patient is compliant, but they're not keeping the tubing clean, not calling when they need the new filters and the filters are dirty, et cetera. At some point, the physician should be advised, but at some point, the physician who prescribed the equipment may well need to be involved, and they may need to reach out to the patient slash, family slash caregiver support mechanism. The sleep clinic, we say sleep clinic, a lot of more and more sleep studies. So the polysomnography, okay, a polysomnogram is a fancy word for a sleep study. Some of them are actually being done at home today, but there's still these sleep labs that are pretty active still today. So the sleep clinic needs to be involved as well, the equipment provider, and all of these parties really need to, in some manner, need to be collaborating with one another, reinforcing important themes, deciding who's, how the follow-up's going to take place, who's going to do it, so that we're not also being perceived as communicating excessively with the patient and the family, that we're doing it appropriately. So a little more on adherence refers to the degree that an individual follows the recommended illness-related recommendations or treatment plan. Adherence failure, use of CPAP for less than 4 hours a night on 70% of the nights. It doesn't mean if it's exactly 4 hours and it's exactly 70%, still may be an issue there, okay? We're really talking about, if it's less than that, that's a critical threshold, and or the lack of symptomatic improvement. So maybe they're using the equipment, but there's some issue with their use of the equipment. It's not being used properly. There's a big leak. It's not being addressed, et cetera. So it's another, if you will, set of criteria that are associated with the symptoms. 5 to 50% of OSA patients reject CPAP within the first week. Okay, 5 to 50%. One of the things that we would do when I was doing home care, it wasn't a formal protocol, it was a guideline. And what we did, we knew that if we could get about 3/4 of the patients to be adherent for about a week, their chances of adhering to the therapy were very good. They were increased. So what we were doing, it wasn't a trick. We were pretty open with them, and we would say to the patient, listen, they're saying, I can't use this. It's too confining. It's blowing all this air in my face. I just can't do this. My husband or wife, it's a problem there, and it's affecting, when they're trying to sleep, it's affecting them, et cetera, et cetera. And we'd say to them, listen, this is what we want you to do tonight. 5 minutes. You literally 5 minutes and 5 seconds. If you have it on that long, take it off. Take it off. If you want to take it off, take it off. Okay. Now, tomorrow night, we want you to do 10 minutes. Okay, we want you to build up to 15 minutes. And we found, for not all, but the vast majority of these individuals, if they were able to make it past the 3rd or 4th night, where they're now doing, let's say, 20 minutes, they would be taking it off. And they thought it was, this was 25 minutes. This was a half an hour. And they found that it was like 6 hours later, or it was a full night's sleep. It was 7 or 8 hours. And you get them to do that a few nights, and they start feeling better. And they don't know how badly they actually were feeling, with headaches and daytime, somnolence and other health-related issues. And you get them starting to feel better, and all of a sudden they're a believer, and they become much more compliant. There is another, if you will, subset of up to 25% of the remaining patients may discontinue after some period of time. Okay, we're talking about at 3 years, at or around 3 years. So you get this resistance up front, and then you get maybe it's apathy, it's overconfidence. It's now I feel fine. I don't think I need to, I don't think I need my CPAP. It's just like I'm feeling better. I don't think I need my medicine, whether it's psych medicine or heart medicine or blood pressure medicine. I'm feeling really good, so I'm going to take myself off of this. There was also that group as well that we need to be aware of in order to keep patients compliant. The benefits of CPAP adherence, again, these are really underscored significantly in the lecture that I actually do on the if you will, more occult consequences of untreated OSA. But let's review a few of them now. So CPAP reduces daytime sleepiness, can have a positive effect on depression and anxiety, and can also enhance the health status of those with cardiovascular disease and related illnesses. Can improve a measure of cognitive performance and perceptions of quality of life. Okay, so what they found is that individuals that were sleep deprived and really had bad obstructive sleep apnea, where they had fragmented sleep patterns, they weren't getting into their deepest sleep, their most restful, recuperating levels of sleep. They were not getting there. And they found that what suffered most with their cognitive ability and their administrative function was not the time it took them to do it. It was the quality of the performance. What I mean by that is this. For example, if somebody with severe under or untreated obstructive sleep apnea was driving a car, they might hit the pedal, what they thought was the brake pedal, with the same amount of speed as they did as somebody who didn't have obstructive sleep apnea, but maybe they hit the accelerator instead of the brake. Okay, so it was that sort of a thing. So cognitive and administrative performance, you can imagine, is a big deal, as is just overall quality of life, which is kind of a compilation of cognitive, of depression, anxiety, or the reduction of that, reduction of daytime sleepiness. There's all this stuff put in, fewer doctor's visits, fewer hospitalizations, things along those lines. And people just reported, I just feel better overall, that my perceptions of how I feel as an individual and the quality of my life is improved. It also, as I alluded to before, reduces healthcare utilization, which really relates to if you feel better and you're not as ill and your comorbidities are at least improving, you're going to use less health resources. You can go to the doctors less. You're going to be hospitalized less. Adherence to CPAP treatment is the largest factor impacting the effectiveness of the OSA treatment. No surprise there. Basic requirements. So now kind of some really kind of scary news in the preceding slides. Okay. Now let's focus on, well, what can we do about it? So one of the if you will, the foundational elements, okay, of a treatment plan for someone that has obstructive sleep apnea is staff who are appropriately trained. Okay, it's sleep technologists, respiratory therapists who are qualified, number one, in performing a sleep study, and number two, either them or a physician interpreting the results. Now, there's software out there that can give a preliminary, interpretation. But ultimately, often the physician, the pulmonologist, the sleep doctor really needs to look at the, if you will, the recording and make the ultimate interpretation and sign off on it. A choice of CPAP equipment which meets the individual patient needs, very, very important. An interface, meaning mask or nasal pillows, that is more comfortable. I'm not saying it's completely comfortable, but more comfortable than the alternatives. And one of the things that individuals complain about is that the mask was too tight, it was pressing on my face, it was blowing in my eyes, it was this, that, and the other thing. So one of the areas that's gotten a lot better with obstructive sleep apnea treatments are the interfaces, the nasal pillows. There's a mask out there called the Amira mask, which is really kind of, doesn't cover the nose, it covers the nares nose, it covers the mouth. It's kind of this hybrid mask. It's a mix between a mask and nasal pillows. It's also very expensive. So I'm not promoting that particular mask per se or interface, but it's one of the ones that is, that's gotten some really, really solid reviews and seemingly has accounted for better patient compliance than some of the more primitive interfaces that were out there. And infrastructure, another requirement, infrastructure that enables timely and efficient communication with sleep clinics, referring doctors, even respiratory therapists, sleep technologists about their patients. The assessment of CPAP adherence, because you can't improve what you're not measuring. All right, I teach a healthcare quality course. In fact, I'm teaching one on right now, not this second, but currently coming down the home stretch, the last few weeks of a graduate level quality management and healthcare course. And one of the principles is, you can't optimize, you can't enhance the quality of something you're not measuring. So one of the ideas here, and applying this to sleep, is the assessment of CPAP or positive airway pressure adherence. To assess CPAP adherence and treatment efficacy, CPAP manufacturers have implemented pretty much universally tracking systems. All right, and they look at things like residual sleep disordered breathing. In other words, that perhaps the patient isn't been improved, but they're still having some sleep disordered breathing, detecting that. Hours of CPAP use, if there's a significant mask leak, how long the mask, how big the leak is, and for how long did it last for. CPAP adherence tracking is now a requirement for Medicare. So Medicare is part of the Centers for Medicare and Medicaid Services. So they're the biggest reimburser in the world. Okay, so they are our, for folks 65 and older in Medicare, and Medicaid, it would be for disabled and folks that are of a lower socioeconomic means. that just are more vulnerable economically. So in this case, Medicare has basically said that, you got to be tracking this. And if you're not tracking it, we're not going to reimburse for it. Several different methods to transmit the CPAP or BiPAP adherence. Most systems use cards, smart cards, SD cards. It's similar, believe it or not, to what you have in your phone. So a lot of it, a lot of it's wireless. It's not entirely wireless, by the way, but the mainstream is, it's either cable or wireless transmission. CPAP adherence profiles are not standardized between different proprietary tracking systems, but there are these significant similarities. Another, just building on this theme a little bit more, USB smart stick memory card, is designed for use with, again, Fisher-Paykel. I'm not promoting Fisher-Paykel. I'm not promoting them, whatever, but just one example. Smart stick works as a miniature USB drive capable of, if you will, transferring therapy data from the smart stick without the need for a separate card reader. Okay. And then to review the data, you just need to do matching software, and there's different softwares, but typically you're matching, the hardware with the particular software as well. So let's look at, drill down a little more on some of these barriers. So you have, it's at the center here, the desired goal is enhanced CPAP adherence. And then you have these, contributing factors: patient-related, therapy-related, equipment-related, and clinician-related. By the way, they're not entirely mutually exclusive. You can have a patient-related and a clinician-related, that it's sort of this contributory issue that both need to work on there. But let's take a look at these individually. So equipment-related, the complexity of the therapy, the device, the excessive mask leak. It might be a small leak. Certain small leaks can be tolerated in a hospital setting, and maybe because of an NG tube. It may be because of some sort of a facial, it's just unusual contour of the face. But in general, you want little to no leak. Portability and battery backup. The device noise, we've gotten a lot better with the device noise, not just for the patient, but for the bed partners as well. The hose length, improper mask fit is a common one. So you've had, you have basically your newer CPAPs are, auto titrating, where within a range, they'll kind of go up and down depending upon patient's position or weight loss or weight gain, things along those lines. You have now ramp features. Well, we had that 30 years ago, but the ramps are better, where basically it builds up, starts at a low pressure, lower pressure, lower flow, more tolerable. Hopefully the patient falls asleep, and then it picks up to the desired level there. The actual interfaces themselves, it's not quite the standard of care, but close to the standard of care is using a humidification, a Passover humidifier. Often it's cold, but they can also have heated ones as well. But with all this comes the importance of actually keeping all of this stuff clean. Therapy-related barriers. So, the adverse reactions that may go unaddressed. So nasal dryness and dry eyes, it's a big deal. Nasal dryness, can be an issue. It can actually make the individual more prone to allergies and infection, as can dry eyes as well, in addition to the comfort, the lack of comfort, the discomfort that can come with both nasal dryness and dry eyes. Nasal congestion. So sometimes it starts off as nasal dryness, and then the body starts kind of readjusting its mucosa, and then ends up being, the opposite issue. Now it's nasal congestion. And nasal congestion is also bad because you got a patient, if it's a nasal mask, you got a patient who's, has a nasal interface, and if they're totally congested or nearly totally congested, it may render the therapy, not non-functional. Skin irritation, or actually skin breakdown, can be an issue. A bloody nose, which often is a function of the nasal dryness, that the mucosa and the vessels have dried up so much that the patient just may be rubbing their nose or something along those lines. The vessels are so fragile, so they start bleeding. The expense of the therapy, I could go a lot of different directions on that, but Medicare by law has to at least bill for 80% of the customary and reasonable charges. Okay, whether or not the patient is made to pay that is a different issue, but there still may be a copay that's associated with that. From the standpoint of the equipment provider, basically CPAP and BiPAP therapy used to be much more lucrative, where there's just a monthly, if you will, rental. Now it basically, after a certain period of time, it'll go to sale, and technically the patient owns it. But then you have the home care company doesn't own it, okay, and you have issues of, well, is the home care company following up? There is a modest reimbursement for some limited follow-up. But again, it's always kind of changing a little bit, but it's a kind of a big deal. And then the second and last point, the governmental policies, it's kind of like it's kind of alluding to that. The reimbursement is part of the governmental policies. Licenses of the clinicians and the drivers, that's pretty fluid. It does vary somewhat state to state. When I did home care, I know we're talking about CPAP or BiPAP therapy, but talking about oxygen, is that initially drivers could not set up oxygen concentrators in New Jersey, knowing that we have folks from around the country, maybe around the world, that are listening to this presentation. It has changed now, where individuals drivers can actually set up the oxygen, as long as a respiratory therapist follows up in short order with them on the setup. CPAP, BiPAP, what's happening more and more today is that the equipment is being mailed out with either a link or a USB, a thumb drive, with the instructions on how to do it. And then the patient and family will get a call or a video visit by a respiratory therapist or a sleep technologist or a nurse at some point, very shortly after the equipment is sent out, to make sure that everything is good. But the days of these personal visits, it's not that it doesn't happen, but it doesn't happen nearly as much as it was. In some respects, it's not a terrible thing, because some folks can be followed up with more readily, who are in remote areas, that are kind of resource starved, that would not otherwise have access to the equipment and access to the follow-up. So I don't want to make it sound all like a bad situation. It's not, but it is sort of a mixed bag. It comes with pluses and it comes with minuses. Adherence can tend to decrease over time. So that's just something a trend that the providers need to be aware of, and really need to kind of, really embrace and say, this is a problem. And it's not just the person's problem. It's not just the patient and the family member's problem. It is now, they're going to be sicker, they're going to be less productive, and they're going to utilize services much more readily, and their overall quality of life is not going to be as good. Nasal pillows is one way to talk about equipment. This is just one example of many, but basically it's not great for mouth breathers, but for individuals who have issues with claustrophobia, have issues with skin breakdown, nasal pillows can be a very, very good way to go. Nasal mask is just one of many. This looks like an old Respironics. Again, some of these have gotten better. Nasal masks used to be the standard of care. They're not as popular anymore. It's not that they're not out there. They're just not as popular, in part because if a patient is a mouth breather, it can be really problematic. And you could lose a lot of, the flow goes in the nose and out the mouth. I'm not saying all of it, but sometimes it's hard to achieve the prescribed, therapeutic pressure for the patient. Full face mask, advantages of it, you're spreading the pressure on the face, you're spreading it out over a wider surface area. A lot of the forehead cushions are made out of a nice gel. A lot of the masks today are also, the actual, if you will, cushion part of the mask is being made from gel, so it can have less, apply less pressure to the patient's face. So it can be, that sort of issue can apply. For mouth breathers, this can be one good way to go. However, absolute contraindication would be if the patient is, if they're nauseous. If they vomit with this on, vomit in their sleep, or just, it could be a catastrophe where it's not just, they didn't just vomit and maybe aspirate a little bit, they aspirated and it was now forced into their lungs. So you can be trying to fix one problem and create another one. But full face masks, by and large, tend to be fairly safe. You just got to, view them in the context of their limitations as well. And then you have this, we call it the hockey mask, but this is the total face mask. Also used, you're now spreading the pressure with which the mask is held on the face is even less because you have a wider surface area. Tend to be pretty well tolerated. The skin breakdown issue is really minimized significantly. Positioning, it tends to kind of hold its position very well. You still have potential issues if the patient vomits. But and there've been a couple reported situations where, because now the eyes are included in this pressurization, that it can be a little bit problematic for people who have existing eye conditions. But by and large, pretty well tolerated. These progressively cost more and more expensive as you gravitate to these. So some of your better interfaces, and I'll put this example in as one of your better interfaces, tend to be tolerated better, but they also tend to cost more. So some patient-related barriers of health literacy, the extent to which an individual understands their condition, understands the basics of the anatomy, the related anatomy, that could help them understand the rationale for their treatment. And just overall, is there health literacy? Individuals that have poor health literacy, tend to be more overweight, tend to smoke more, drink more, they eat more fatty foods, they don't exercise, et cetera, et cetera. They tend to have worse quality of life. Now, individuals can smoke, drink, be overweight, and still and understand that that's not good for them. But that's not necessarily a health literacy issue. That's just, I understand what I should be doing, and I'm just not going to do it because I like to smoke, drink, and eat, whatever. But there are individuals out there that really do not fully grasp the potential harm they're doing to themselves by, having a poor diet, by drinking and smoking period, drinking excessively, not exercising, et cetera, and just exhibiting other bad behavior. So the fact of the matter is, some individuals out there just have low health literacy, and it's very much a barrier, not just with obstructive sleep apnea, but the healthy lifestyles in general. Ambivalence is kind of what I was referring to. Well, I smoke, I drink, I'm overweight. I don't really give a what. I'm going to do it anyhow because I'm ambivalent, and I'm going to do what I'm going to do. And if I get sick, I'll go to the hospital, or I won't go to the hospital. I'll just die at home, whatever the case may be. But it's this very, I'm going to do what I'm going to do attitude. A lack of family or other social support is certainly amongst them. What may or may not be interesting to some of you is the fact that, when individuals report when they're using CPAP or BiPAP, and they report the bed partner has issues with it, when that's drilled down on, many times it's not the bed partner. It is the patient's perceptions of the bed partner. Many times bed partner doesn't really care, as long as their loved one is going to be more healthy, going to be in a better state of health because of that. That's really what they're focusing on. Patient economics, so really we're talking about the ability to pay a copay, things along those lines. Or if there's out of pocket because a special interface or something along those lines, it can be a potential barrier. Many home care companies and manufacturers will work with such patients. So I really don't see home care companies, again, it wasn't just us, but us and the other companies that we would collaborate with. If patients needed more filters and it wasn't covered by insurance, we're not going to withhold the filters. We're absolutely going to, we're going to work with them. So I don't want to drill down on that too long, but it can, economics can be an issue. Lack or insufficient reimbursement can be an issue, but there are some reasonable workarounds to those. Psychological barriers such as claustrophobia, just fear in general. It just doesn't fear. It's individuals that have out and out claustrophobia, fear of closed spaces. There's other individuals just like, I don't like this thing. I don't like it blowing in my face 100 liters per minute. Physical limitations, the inability maybe to put the mask on and off, at night, or if they need to go to the bathroom in the middle of the night, turning it off, taking it off, going and putting it back on, things along those lines. Sometimes that's not necessarily a physical limitation. It's just, I sleep deeply, and then when I get up, I can't get it back on. So it may be physical, just functional issues. Less severe factors and little or no perceived benefit from the therapy. That's where we really come in and showing them some of the data that's out there. Use of prescription, non-prescription drugs and alcohol can also be a potential barrier. Hard to put a mask on, right, if you're going to bed drunk. Claustrophobia, let's talk about that a little bit, because it does unfortunately affect a notable number of people who are CPAP or PAP candidates. And claustrophobia is a form of special phobia, fear, that entails extreme anxiety and panic caused or elicited by closed spaces. Almost 1/3 of sleep apnea patients endorse, meaning they report CPAP-related claustrophobia. 1/3, it's a big number. CPAP-related claustrophobia was perceived as one of the largest deterrents in PAP or CPAP therapy. Clinician is a little more on clinician-related barriers. Poor patient relationship, just not being able to establish a good rapport with them. Lack of clinician follow-up, expression of doubt, basically, concerning the therapeutic potential or benefit, and then possibly, us contributing to falsely elevated expectations. You're going to feel like a new person after 3 days, and then they don't feel like a new person. It's like, wait a minute, this sucks. I'm not going to use this. That's not. So we need to be realistic on saying this is going to help you. It's going to take time. It's almost like weight loss. You're not going to see it the first, second, third day, but you will see it over time. You're going to feel better. Likewise, you're going to feel better over time, and some of it's occult in that you will be better health-wise, but you may not feel it all on the surface. Unwillingness, inability of the clinician to educate the patient, just someone who's just not good with communicating. Not somebody who's normally good and having a bad day, but somebody who's they just are not a good educator, not a good communicator. They lack empathy. They lack, the rudiments. They don't have good interpersonal skills. Lack of knowledge on the patient's medical history, so us not doing our homework, other medications the patient may be taking, and things along those lines. And then there's the barrier no one wants to talk about, and it's to do with reimbursement. So, reimbursement from CMS and private insurance is a troubling barrier, and it's basically been, it's been reduced. Over 30 years, it's been reduced. Reimbursement for CPAP and other respiratory interventions has been cut dramatically over the past 20, even more than 20 years, but 20 to 30 years. Such reductions leave fewer resources for proper equipment, patient education, and follow-up to address, compliance challenges. Now, again, a lot of that follow-up is being done through telehealth, whether it be actually a telephone call or, a device where it's a video session and things along those lines. A lot of that's being done there. So there's the better ability, more efficient use of the clinician's time to follow up rather than driving out, or maybe a drive out, maybe ultimately necessary, but at least 9 out of 10 times following up effectively, but not having to have all that drive time in place. Interventions. So we talked about the different barriers. Now let's talk about the interventions, which you can imagine they kind of complement each one of those preceding slides in the barriers. So they really kind of address those particular barriers. So, some of the interventions that can be done regarding equipment and therapy, heated humidification to relieve the dryness, runny nose, nosebleeds, etc. Nasal spray, again, CPAP modalities, auto titrating, bi-level PAP, etc. Refit the interface, change the mask type. So I alluded to some of this too, those, kind of a hybrid nasal mask, or the Amira mask that I talked about, nasal pillows, some of the comfort features, the ramp, which again is building up to the prescribed pressure over often 15 to 30 minutes, quieter equipment, battery backup in case there's a power outage or someone's traveling, or they're traveling a very far distance, a flight, let's say to Australia from the East Coast of the United States, probably sleeping on the plane, or going in the other direction, taking a jet trip to China, or to somewhere in the mid or far east. Expiratory pressure relief. So just and again, if there was some issue with exhalation, etc., that's some sort of an override that's going to not cause the patient any discomfort or any excessive discomfort. Contour pillow that works, so this is one of the things you can actually use in concert with. So there's things that we can do to make the patient more comfortable. Some of these contour pillows, I talk about this a little bit in some of my other related sleep lectures. We talk about some of it is comfort and compliance with the therapy. Some of it is patient airway positioning, so that perhaps combined with other if you will, approaches, more conservative approaches, weight loss, repositioning, eliminating or minimizing alcohol consumption, smoking, things along those lines. This can be, it can be very helpful alone, but particularly with, many types of CPAP and BiPAP masks. Again, ease of use, sleep comfort, again, CPAP compliance, enhancement, neck support, alignment, etc. And then it also reduces mask leaks and pressure on the face and overall mask discomfort. Some of the patient and clinician intervention, so family social support, sometimes that's in place there, but a lot of the when a CPAP is set up initially, a lot of the home care companies will actually provide links to support systems for both the patient and the family, and linking folks that are on similar therapies, because you'll find that, oh yeah, I had that problem, but this is what I did. So a lot that can be learned from people going through the same experience, and maybe one patient is further behind, just getting started on it. Another patient is 6 months in and they had trouble at first, but they overcame it in certain ways. Sharing those experiences can be invaluable. Bed partners acceptance, I alluded to that before. Many times the acceptance is there, but it's the actual patient's perceptions of it. Suitable education training on the equipment really is just irreplaceable. And some of that is education's a process, it's not an event. So we did the initial education and we did the initial training, but now it's the follow-up, the reinforcement, etc. Imagine somebody telling you you have obstructive sleep apnea, this could happen to you, that could happen, you get high blood pressure, blah, 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 blah. And then you're trying to absorb all this stuff and you're like, wait a minute. So, it's like people can only absorb a certain amount over a certain period of time. So you need to give it to them in doses. So it's the initial education intervention, then repetitive follow-up ones. Cognitive behavioral therapies and motivational enhancement, and again, rapid response to difficulty. So if the patient's having challenges with compliance and comfort, is that the home care company, many times it's who it is following up in a prompt manner, is able to help resolve these issues. And compliance programs, so patient education, close follow-up, intervention. As far as the education goes, it's education on the disease state. What's the diagnosis? How severe? Why does OSA occur? Basics on that. Those first few slides that we look at. What are the potential comorbidities? And that's a little bit of scared straight, but more just reality. This could happen. We're not saying it's going to happen to you, but it could. You put yourself at high risk for these following disorders. Why do this to yourself? Why be sicker than you need to be? What should they expect? Equipment, how it works, how to inspect, replace, maintain, etc. when it's required. And what to do if you run out of stuff, if you have a question, etc. What support is available to ensure the patient's success in therapy overall? Should include general advice, patient's lifestyle and medical issues. So, smoke should be advised to stop, but also should be provided with some of the resources to help them stop. Alcohol should be avoided. Avoid nocturnal sedatives, sleeping tablets. Advice regarding weight loss and things along those lines. Sleeping position is also an important element as well. Ongoing management. So it's suggested that the follow-ups occur, the first day or two, but then at 7, 30, 60 days. And then after that, obviously can be spaced out to a much greater period of time, often a year, up to a year. During these follow-ups, the provider should determine, the patient's usage from the monitoring of the device, calculate the average daily number of hours. A lot of times that's done as part of the actual function of the platform, the monitoring platform. Check the device, the humidifier for satisfactory operation. Check the filters, the mask, the headgear. How are you cleaning it? How often are you cleaning it? What are you using to clean it? And at some point, it's been cleaned so many times, been used so many times, it needs to be replaced. So what we do I mentioned that a unfortunate reality is claustrophobia is an issue. And, one of the approaches, one of the kind of proven approaches, if you will, if an alternative, less confining interface, mask, nasal pillows, are not effective, then exposure therapy may be considered. So the first line is, let's try a different interface that's less confining. Second line is, let's try to get the patient less susceptible to claustrophobia. And claustrophobia in and of itself, it's a fear, but it's basically the combination of at least two fears. One of them, fear of restriction. Second one is the fear of suffocation. Exposure therapy is indicated for individuals sleep apnea who are unable to tolerate because of anxiety reactions secondary to claustrophobia. And then you have some contraindications here. Unstable. You don't want to force somebody to, to do something that could trigger some, psychiatric symptoms or something along those lines. So we're not talking about that. But we're talking about somebody who, potentially can successfully be coached on complying with the therapy. And the rationale is, the individual confronts their fear, of the object or situation. The individual is supported. They're introduced to it or exposed to it in a gradual manner over time. And what happens with many individuals is the anxiety decreases. The effectiveness of the exposure therapy stems from learning to tolerate and manage anxiety without the need to escape. And exposure therapy increases the individual's perception of control over fear. So it really will start with, the mask, the interface is not connected to anything, honestly. Or maybe, it's just there. It's connected to a hose. It's just there. And they put it in their hand and they hold it on their own face. No one's holding it on there. You only put the headgear on. And you start with baby steps. You start small and you work from there. And this is a little bit more, of what you actually have, from a granular level. What would it actually, comprise of? Turn on the CPAP, hold the mask over your nose, practice breathing. So I'm not going to read this whole slide to you. These are available. Obviously, you're listening to this presentation right now. But then turning the CPAP airflow on, wear the mask. So now you went from no airflow to airflow. And then the third one is, take a nap during the day with the CPAP machine on. You wake up, your sleep, your nightly sleep does not depend on it, but hopefully you can move in the right direction. And then wear the CPAP actually at night. So it's this gradual introduction to it. And this is a variation of compliance. I alluded to this, but ensuring that all barriers, that we discussed above are minimized. Proper interface, humidification, ramp, auto titrating, proper education and follow-up. And then again, you ask the patient to try it for the first 5 minutes, et cetera, and they gradually increase. And what we found, and we weren't doing this for the sake of research. We were doing it for the sake of process improvement for our home care company. And we found that it was nearly 80% of the patients were compliant by the 5th night. Okay, now we didn't take this out years and years, but we found that because we really had a big problem. It was about 50-60% compliance. Okay, and we got it. We would have loved 100%, by the way, but we were just like, okay, and that's pretty much, it was pretty much what we ended up doing. But we kind of filled in some of the gaps here. It was a little more structured follow-up and things along those lines. But it seemed to work. It resulted in demonstrable improvement. Some take-home points. So untreated obstructive sleep apnea has some very serious consequences to the individual patient, those around them, and society in general. I've probably really drilled that home really significantly. Given the nature of positive airway pressure involving blowing air at often over 100 liters per minute into the patient's face and airway, it's no surprise that many barriers exist. I'm sometimes amazed as many people are compliant that actually are. However, there are some strategies which can offset many of the barriers and enhance compliance. And CMS reimbursement will continue to be a challenge. Not picking on CMS, by the way, but it's just a reality we're all with. However, overcoming these barriers requires careful planning, commitment to success by multiple stakeholders, the ones that we mentioned. Us, the physicians, the patients, the folks at the sleep labs, et cetera, and an ongoing follow-up collaborative approach, including the patient's clinicians who actually serve them as well. Some selected resources are here, including I had to put a plug in for our latest edition of Egan's Fundamentals of Respiratory Care. Bob Kesmarek passed away not so long ago, but he was very much privileged working with him. And there's one chapter in Egan's that's actually dedicated specifically to sleep medicine, but there's other chapters in the text as well that relate to it as well. The clinical assessment in respiratory care by myself, formerly with Dr. Craig Scanlon. We just came out now, and then others as well. Spriggs, the third one here, Essentials of Polysomnography, is kind of a classic out by Jones and Bartlett, and the most recent edition is out in 2020. So with that, I really want to thank you guys for coming out to today's lecture. I really hope that you learned something by reviewing this information, as well as our other presentations in sleep and those beyond that as well. Terry and I and A&T Lectures want to thank you. Hope that you come back to us for either our virtual lectures or our, again, desynchronous ones such as this. Thank you very much. Have a great day.